So thank you very much for inviting me to participate in your symposium today and for your kind interruption. Unfortunately, with 9 hours of jet lag and we were enjoying your lovely city last night, I almost missed my lecture, but here we are. Good morning. So this morning I've been charged with the task of 2 drug regimens, selecting the right patient, and in light of the other discussions that are going to happen in this session this morning, I decided that I would limit my comments to the naive patient, and others are going to address switch. So these are my disclosures, and I have participated in many of the clinical trials that led to the development of 2 drug protocols. So let's take ourselves back. Ever since 1997, I believe, it has been drummed into our minds and to those of our students that you need 3 drugs to adequately treat HIV therapy. And we were all happy with that. And it worked for most of our patients. And so we might ask ourselves the question, so why are we pushing the paradigm now? Why are we deciding that we only need 2? Well, why would 2 be better? So if you could get away with 2, there would potentially be less short and long-term toxicity. The less drugs you have, the less likely there's going to be any interactions. And then you've save a class so that if somebody gets into trouble in the future, you do have an other class of drug to use as part of that rescue therapy. Sort of a big question is why use 3 if you only need 2? And given all the concerns about costs and things in the world these days, you know, obviously by using 2 drugs instead of 3, the overall costs would be less. And it's not that we didn't try. And I'm going to start to show my age here. And we really have been trying to do 2 drug regimens ever since 1999, and that original study was a combination of indinavir and efavirenz. And if we look back on things, and for those of you who were around at the time, how in the heck could a patient ever take indinavir and efavirenz without all of that toxicity? And you certainly see that every time over the years we tried, and we tried them with proteases, we tried them with integrase, we tried them with NNRTIs, and we were not successful. And this was the trial, this is the NEAT study that was conducted in Europe that compared darunavir with tenofovir emtricitabine to darunavir plus raltegravir. This was in naive patients. So we took the most potent protease inhibitor we had at the time, we combined it with the first integrase that we had at the time, and all of us in our heart of hearts thought, absolutely, this study is going to work. But in fact, it did if you look at the primary endpoint, and the primary endpoint was non-inferiority, and if you can see in the top bar there certainly was non-inferiority for the primary endpoint. But when we started to pull it apart, and we tried to take the most extreme patients, those with the highest viral loads and those with the lowest CD4 counts, this regimen started to fall apart and wasn't not inferior. And so those in the fields always say, well, when we stress a drug to the limit and it doesn't perform, that makes us worry that it's not as good. So that's when everybody really lost faith in the possibility that 2 drugs might work. Because if a potent PI and a potent integrase wouldn't work, what 2 drug combination was ever going to be effective? But then things changed. And it was Pedro Kahn who got brave. And again, his study was largely driven by finances that made them do this. And they did this study called GARDEL in the day, when patients were randomized to receive either Kaletra plus 3TC or lamivudine together with Kaletra and 2 NRTIs that could be chosen by the investigator. And this was the Kaplan-Meier plot showing his original results, showing that the 2 drug combination in red was more effective than the 3-drug combination in blue, although it did not meet statistical significance, but did show that 2 drugs were greater than 3. And then when he stressed it and he looked at the highest risk population, those with the highest viral loads, it performed even better. And the reason largely was because there was less side effects associated with the 3-drug combination. There was only one person in this trial that failed and broke through with a resistant mutation to 3TC. But you know, the field wasn't ready for that. And the field had moved on. Most of the field was not using Kaletra anymore. AZT was one of the components of the background, and people weren't using it anymore. And so people said, well, you know, Pedro, yeah, this is very interesting, but nobody really engaged or took on this practice. But he says, oh, I'll show you anyway. And so what he did at the time is then did the ONDAYS study, which used now darunavir, boosted with ritonavir, with 3TC as his 2-arm comparator. So now using the boosted protease that everybody was using at the time, together with 3TC, and did show the same thing. So 2 different proteases with single 3TC performing as well. But again, the field had moved on, and so yeah, that's very interesting, but you know, we've all gone to integrase inhibitors now as first-line therapy. So the debate began. Is this potent enough? Will 2 drugs last as long as 3 drugs? What about those late presenters, people who come very, very late in their disease? Is that going to work? We don't believe the barrier to resistance is high enough. And what happens if somebody misses their dose? Is this going to fail? And because we're worried about this, are we now going to have to manage their viral load more frequently? Are people going to be able to tolerate this? And is it really going to have any effects on long-term toxicity? And then the old arguments about what about the sanctuaries and residual inflammation? And so there was every argument in the book why we would not accept 2-drug therapy. So then the integrase inhibitors came, and again, it was Pedro once again who says, okay, I'm going to show you that 2 drugs are as good as 3. And I think everybody in this audience is aware of the GEMINI trials, which compared dolutegravir with 3TC to dolutegravir with Truvada and FTC. And this is the data from the week 144, and we don't need statisticians to show us that those 2 curves are equal or non-inferior. And then, well, the skeptics, it's not going to work. There's going to be resistance. And this is data that was presented out to week 144 and demonstrated that over that period of time, there had only been about 20 confirmed virologic failures. And of those, very few had enough viral load to be able to be looked at for resistance testing. And in fact, there was only 1 case in the dolutegravir and 3TC arm that developed any resistance, and that patient developed a 3TC resistant mutant and probably an archived and an RTI mutant at the same time. So then what about some other potential benefits? So it's good virologically, but do we need something more? Do we need that this drug is going to help patients? And so people started to look at submarkers. So one of the things that was looked at is these renal biomarkers. Another thing, and as you can see, is the 2-drug arm in blue performed better than the 3-drug arm in orange for all of these renal biomarkers. But do we really change practice based upon little glitchy changes in one's renal biomarker? Then they looked at bone. Of course, we're always worried about bone with tenofovir. And again, what they did is looked at some of these bone biomarker turnovers, and again was able to show statistically significant changes in favor of the 2-drug combination. And then lipids, same idea, trying to look at the various components. And as you can see, the important ones there, the LDL cholesterol, was improved in patients on the 2-drug combination. And now, of course, everybody's talking about weight gain. We still have that argument. Is it the integrase inhibitor? Is it tenofovir alafenamide? Or is it the removal of the tenofovir And you can see in the GEMINI studies that the weight gain was greater in the 3-drug combination as opposed to the 2-drug combination, looking at approximately a kilogram difference in weight at the week 144. So what about transmission? You know, we get a way of virus within our blood. What about virus in various bodily fluids that might be transmitted to someone else? And so what they did was try to look at viral transmission, comparing the 2-drug arm to various 3-drug arms, and was able to demonstrate that the number of times you can actually detect genetic DNA in vaginal fluids was very similar between the arms. Well, what about suppression? Will the 2 drugs suppress the virus as rapidly as possible? And again, these are models based on different studies and shown in parallel. And it's really the integrase inhibitor component of the combination that is driving that suppression of viral replication. So 2 drugs were suppressing as quickly as 3. So if we add the whole thing up, looking at some of those arguments, is it as durable? Well, we have non-inferiority out to 144 weeks. We've looked at more sensitive markers, so rather than using a 50 cutoff of viral load, they looked at 20 copy cutoffs. They even looked at 1 copy cutoff and did not find a difference. What about this blipping? We all worry about blipping. There was no difference in blipping between the 2-drug arm and the 3-drug arm. And as I showed you, viral suppression was as quick. And so it appears that the barrier to resistance was as good, as there was only 1 case over 144 weeks of a resistant strain. And we showed better tolerability, quotes on quotes, in terms of better renal and bone biomarkers and less improvement or less increase in weight. So, where are we at? So, what populations should we not consider for 2 drugs? Well, first of all, we do not want to use them in people who have transmitted resistance, so people who have known either 3TC or integrase resistance. Now, that's possible in some countries to have that information, and others it's not. But clearly, even in those countries where those tests were available, the incidence of transmitted resistance to 3TC and integrase are declining quite considerably. Clearly, we would not want to use this in persons with underlying active hepatitis B because we would like both components of the 3TC and the tenofovir in order to suppress that virus. We try to avoid this drug in somebody who has active TB requiring therapy because of the drug interactions with rifampin, making that very difficult. But there are some populations where the data is not clear. And I would argue that the data in these populations are likely never to be resolved. So the first one is pregnancy. And I deal a lot with issues related to women and their treatment. And if a woman was on a 2-drug combination of dolutegravir and 3TC, got pregnant, has been suppressed for years, what is the argument? Should we put her back on 3 drugs because that's what the books tell us she should be on 3 drugs? Or is it really the fact that her virus is suppressed and therefore she's not going to transmit to her baby? That's my feeling. But you know, there will never be the clinical trial that's going to prove this. Can you think of how big that clinical trial of taking pregnant women on 3 drugs versus 2 drugs to prove this when transmission rates in pregnancy now are less than 1%? So the guidelines are never going to accept this because there's never going to be a clinical trial to prove this, but I think you need to think about it clinically, whether that be important or not. Now, on the other hand, if I had a woman coming to me and saying, hey, I want to be pregnant, I'm not so sure I would start her with a 2-drug combination. I'd wait till after she was pregnant. There is still this argument about high viral load and low CD4, and I'll come to those slides in a second. The other thing is because of this whole weight gain question, you know, what do we do for somebody who comes in overweight? Do we start those people on an integrase inhibitor-based therapy? And again, I think we will never have the data to prove that. And then lastly of all is pediatrics, and I know that the 2 drug combinations are moving into the pediatric community. And I think for those of you who take care of children, we know that children are not always their best with their adherence. And are we going to run into issues if this gets moved into the pediatric population? So here's the whole question about the high viral load and low CD4 count. This is data from the GEMINI 1 and 2 trials. And as you can see, for the high versus low viral load, the outcomes were relatively the same. But the problem is that the GEMINI trial did change as it evolved. And when the GEMINI started, people were not allowed into the trial if their viral load was over 100,000. And then midway through the trial, they changed the rules. And so the number of people with very high viral loads at entry is actually very small. And then we have this other issue of low T counts. And again, looking at these curves, the individuals who had a low T count as defined by a T count less than 200 at entry, they didn't do as well. And we have been given lots of explanations for this, largely that these were administrative problems, and most of the people who did not take or who didn't do well with a low T count had other reasons for leaving the trial that were not necessarily related to the drug. But I think there can be many arguments around that, and perhaps people who are sick or not well may not be able to take their meds as regularly or some other reason. And again, the number of people in that component of the trial are small. So in attempts to try and increase those numbers, they then took the patients from the STAT study that I think you heard about yesterday as rapid starts and tried again to demonstrate to us that there's enough people with high viral loads that respond well. But again, the numbers are still really small. And therefore, many of the guidelines continue to say, do not use this 2 drug combination in the people with the highest viral loads. But what else don't we know? And I think one of the things is we need that extra advantage, right? 2 drugs work, that's great, saves money, less toxicity. But what about all of those lab things I told you about? Bone biomarkers, renal biomarkers, lipids. Is that going to translate into clinically important findings? And that we don't know. Another argument is, what if the 3rd drug in this study had been in TAF instead of TDF? Would the outcomes have been better? Would those biomarkers be different? I think most people do believe that TAF is a safer drug than TDF, but there are emergence of reports in the literature now that maybe TAF is not as benign as a drug as we used to think. What about other anchor drugs other than dolutegravir? So far, that's the only one that we have, and can we translate these findings into other 2 drug combinations? And then lastly of all, that test and treat thing that you learned about yesterday, can it be done if there's a risk of 3TC resistance? And I think you just basically have to know your own population to know about that. So who's the ideal patient? And I think from the virologic characteristics, there's somebody with no underlying resistance, they have low to moderate viral load, they have high to moderate CD4. The patient characteristics, it works for young, it works for old, doesn't matter if they have comorbidity, but they cannot have that underlying hepatitis B. And I think my last point is, if you're not sure, there's nothing wrong with starting on 3 drugs, getting them under control, and then dropping them down to 2 drugs later. And I think, the high viral loads, low CD4 count might be that very person that's a more prudent approach to take. This is the only 2-drug regimen that we're using very much at this time, and is the only one that is currently in practice and on guidelines. We were very hopeful for another 2-drug combination, which is islatravir, which is the NRTTI combination with doravirine. And we were all hopeful for this being another drug that we could use as part of a 2-drug combination. But I think, as you've heard, there's been a little issue with the medication that was causing some drops in lymphocytes, which has now been explored, and they're reinitiating their clinical trials with lower dose. So there may be another 2-drug combination orally that we will be able to use in the future, and later on in this symposium we'll be talking about the injectable ones. So in summary, in terms of 2-drug regimens, my argument is it's not about the number of drugs, but it's more about the potency of the combination and the forgiveness of the regimen together that gives rise to that barrier to resistance. That reverse transcriptase inhibitors, for whatever reason, seem to be an important part of the combination if you're using two drugs. And I think finally, the field now is starting to embrace this approach. I think there was a lot of hesitancy at the beginning for some of the reasons I gave you. But the new question, and the question that I ask when a patient comes in, is there a reason why this person can't be on a two-drug regimen? So I'm going to end my talk there.